Thanks for inviting me to speak. I'm going to talk to you about the new therapeutics that might be coming in Alzheimer's disease. I'm going to focus on drugs which might affect the development of the disease or the progression of the disease, rather than treatments like behavioral treatments or even drugs which affect the neurotransmitters. So very much drugs which might modulate the progression of the disease, if you like. Now, in order to do this, I need some sort of framework in which to build these ideas around, really. And the framework which most drug companies have used is the amyloid cascade hypothesis. It's by far the dominant hypothesis in Alzheimer's disease. It's worth noting that it is actually based on these, well, it was originally based on these very rare families who inherited mutations that increased amyloid. There are some holes appearing in the cascade hypothesis, but it still remains the hypothesis which most treatments are based upon. So in essence, and I'm sure most of you are aware of this, the amyloid cascade hypothesis says that environmental and genetic risk factors increase the buildup of amyloid. That could be in the form of soluble amyloid or amyloid plaques. And amyloid plaques or soluble amyloid are responsible for all the downstream changes that we see in the disease. So they're the root of all evil, if you like. They're responsible for the buildup of intracellular tangles, the buildup of inflammation in the brain, shown here with microglial cells, and then neuronal cell loss, and then, of course, dementia. So if we look at this cascade, we can see sort of pretty well immediately that the obvious point, if we wanted to intervene in the development or progression of the disease, would be to hit the development of amyloid, and that certainly was the first focus for treatments. So in order to understand how we might hit amyloid, you need to know how amyloid is actually developed in the first place. And in essence, this cartoon shows that basically amyloid, which is the little red molecule there, is derived from a much larger molecule called amyloid precursor protein, the one in blue. And what seems to happen is that in Alzheimer's, we get excess of beta secretase or gamma secretase, which cleaves out that molecule, which forms soluble oligomers, which then aggregate to form the plaques. So you can see immediately that if we inhibited gamma secretase or beta secretase, we might inhibit that process. And there's reason to believe that these two processes may act differently. So both approaches are worth pursuing. And the first approach was really trying to inhibit gamma secretase, and this is quite a historic series now, because it happened quite a long time ago. But it's worth just remembering this. The first gamma secretase inhibitors happened around about 2008. It was actually, I think they were run by Gordon Wilcox in Bristol, and that first study of fluoroprofen showed no difference in cognitive scores. And what was worse was that two further studies, two phase 3 and a phase 2 study, actually showed in both cases a worsening of cognitive scores. And so these studies are actually halted early. So that didn't portend well, really, for the beta secretase inhibitors. But as I said, they have different properties, and so they were pursued. Now, the beta secretase inhibitors started off with Lilly in around 2013, and those early studies were stopped because of liver abnormalities. And what we've seen since then is that, that these studies paused for a little while, but then they continued. There was renewed interest in beta secretase inhibitors. And what we see, if we look briefly through the slides, what you can see is that initially Merck did a study in Alzheimer's, and then the studies developed with AstraZeneca moving into mild cognitive impairment due to AD. And then they moved all the way through to the Novartis studies at the end, which are actually based on patients who actually are cognitively normal, but are at risk of developing the disease because they got E4. So you can see that the drug studies essentially failed in Alzheimer's. And so the movement was towards earlier and earlier and earlier treatments, which is something that Jay sort of echoed, really. The worst thing about the beta secretase inhibitors, though, was that firstly, the liver abnormalities and major side effects of these drugs continued in all of these studies. In fact, liver toxicity was also present in that atabastat study. But what was very common were things like weight loss, psychiatric symptoms, and pigmentation problems. I think the AstraZeneca study had patients had, I think we were involved in that, and patients had white hair. The major problem, though, and you can see this all the way through, is that a large number of these studies also, like the gamma secretase inhibitors, show worsening of cognition. In fact, pretty well all of them have shown this, except for the AstraZeneca compound. There's been a worsening of cognition in pretty well all of these studies. And that's through the different phases of treatment as well, even if you start very, very early, the last study. So I would say that these compounds are probably all, I've said this before, and I was wrong, but I think these studies are probably not going any further. So how else can we stop the production of amyloid if we still believe that the amyloid is the cause of all evil? Well, the first inroads into this was demonstrated by this brilliant guy, Dale Schenk, who basically what he did was something extraordinary. He injected mice who've been genetically engineered to produce amyloid because they have the APP gene inserted into their genome. These mice, if you give them amyloid into their bloodstream, they develop antibodies, AM1792 here, and those antibodies appear to cross the blood-brain barrier and prevent the development of amyloid in this mouse. And he went on to do further studies which showed that if the mouse already had amyloid, so equivalent in that case to Alzheimer's, the injection of A-beta-42 also produced antibodies, and these antibodies removed the amyloid. So with that sort of latter demonstration, they moved very, very quickly into clinical trials of this compound, AM1792. And I think it's worth just reviewing a couple of slides about what happened to that active immunization study, because I think it very much explains the direction in which all these A-beta immunotherapies have followed through ever since then. So this slide, you'll forgive me if I show these slides, because these are all, these studies are actually done in Southampton in MARC. This was the slide of a patient who received AM1792, the first lady to ever come to post-mortem following immunotherapy. If you look at this slide F is actually a section of temporal cortex in a control case, lots of dots, and those dots represent amyloid plaques. But if you look at slide E, you can see this is actually a slide from this lady's temporal cortex, and you can see all the plaques have gone. There's a bit of amyloid in the blood vessels, but essentially the amyloid has been removed. So as predicted from the mouse model, injecting amyloid, producing this antibody, resulted in successful removal of amyloid from that patient's brain, which is quite a remarkable finding. And one of the only times I've ever been happy being on call all weekend, because this happened on a Friday afternoon, and we looked at this lady's looked down the microscope, this lady's brain, and I thought, my God, Alzheimer's, we've cured Alzheimer's disease. Well, they've cured Alzheimer's disease, and we're seeing it for the first time. Now, there were problems with this case. This lady did, as you can see in A and B, have some side effects, and she was one of the few people in the study who did, and she had an encephalitis, and this was thought to be caused by an infiltration of T cells. So this first slide really just shows you that the active immunization appears to work, but there are problematic side effects. Now, we went on to follow a number of these cases. I think we followed over 20 of these cases so far, but this is just the first 8 cases. And what you can see here, in the top left-hand corner, you can see a control section of temporal cortex, lots of dots, lots of amyloid. And what we can see in all the others is a variable amount of amyloid being removed. So case 3 coming directly across, you can see there's no amyloid. Case 7, no amyloid. Case 8, pretty well no amyloid. But some of the cases, such as the one in the middle, doesn't seem to be that much different from the placebo, the unimmunized AD case. So immediately this slide tells us that active immunization gives a very variable response. So there may be better ways of trying to activate the immune system. But probably the most worrying part of this whole slide is their mini mental state scores. Now, all of these cases started off with mild to moderate Alzheimer's. Their mini mental states were in the order of about 20. But what we can see, I think with one exception, case one of a chap who died very early in the study with a ruptured abdominal aortic aneurysm, all of the cases, with that exception, have mini mental states of 0 when they died. And that includes case 3, case 7, and case 8, where the amyloid has been removed. So this raised some questions about whether or not one should be targeting the disease at Alzheimer's level, or whether we should be starting earlier. Maybe it's a bit too late if someone's already got Alzheimer's. Maybe we should be going for a more immunized sort of vaccine type approach. So where are we in the immunotherapy studies? Well, this is a list of all of the compounds that are being trialed at the moment. Some are very early phase 1 studies, some phase 2, but a number of these have now moved to phase 3. There's basically various different approaches being tried. So the number one is the original AM1792. You inject the whole length of A beta 42 into the bloodstream, producing antibodies. The other main method for active immunization is to just inject a small part of the amyloid molecule. And the reason for that is that if we just give a small part of the molecule, which is predominantly focused in the N-terminus region of A beta, we don't tend to get that encephalitis. So the reason for these small epitopes is to reduce the risk of the encephalitis we saw in that first case. And there's a number of different examples of it there. But by far the biggest approach is this passive immunization approach. That too also uses the fragment monoclonal antibodies, which are aimed at the N-terminus part of the molecule. But in this approach, you instead of getting the person themselves to develop the antibodies, you actually give the antibody itself direct. And with that method, you can control the dose, and also you can therefore remove that variable, which is the person's response to the drug. And so you might prevent only some people having amyloid being removed from the brain. So that's why the passive immunization approach has been so popular. Lots of different examples of that. And then the final, number 4, is a bit of a maverick approach. Doesn't really fit in terribly well with the others, but it is a passive immunization approach. And what people have done is give immunoglobulin directly from from donated plasma. And the idea here is that this plasma will contain naturally occurring antibodies to A beta 42, as well as having other anti-inflammatory properties. Now, when we look at this list, particularly the lists for numbers 2 and 3 here, we see a whole range of different compounds. And one question that might be asked is, why do we have so many? Why do we need so many if they all do the same sort of thing? Well, the reason that the drug companies would argue that we need so many is that they all act slightly differently. So these compounds, we can see, hit various different bits of the A beta 42 molecule. As I say, they're mostly focused around the N-terminus part of this molecule for the reasons I've said, but they argue that if they hit various bits, they've probably got a better chance of attaching to the A beta molecule. Lilly's compound donanemab is a slightly odd, well, I should say different antibody approach, because it doesn't target the A beta 42, it targets a post-translational modification of it, which has got a pyroglutamate addition. And that's interesting because this pyroglutamate addition, which is normal part of processing of A beta 42, aggregates. So that Lilly compound is very much focused on plaques. And that's the other reason why drug companies will say we need so many different molecules here, is because all these compounds differ in their ability to either focus on plaques or soluble A beta. Some focus on both. I think what's interesting from this slide is if you look at Lilly, solanezumab was very much marketed on the idea that it hits soluble A beta, and that was clearly the molecule which was causing the problem as far as they were concerned. But they're now also producing a compound which very clearly focuses on aggregated plaques. So a very much wide variety of different approaches here. So how have they done? This is just the ones that have come through really to phase 2 and phase 3. I've removed the ones in earlier development. The ones in red are the ones that have failed and have clearly failed. In the passive immunization studies, bapineuzumab, for instance, and solanezumab, for instance, used huge numbers of patients, very well conducted studies, many thousands of patients in these studies, and they showed no difference whatsoever. Active immunization, amylomatide also looked very promising at one point. It's also known as CAD, but that's also clearly been described as failing now. I think what's interesting, one of the compounds which is interesting in the active immunization is AD02. And it's interesting because it just shows an element of desperation in the people who are developing these compounds. AD02 showed no evidence whatsoever of showing any efficacy in Alzheimer's disease. But they seem to be claiming that their placebo might have an effect. So as a sign of desperation, AD02 at one point was seen to be developing their placebo. So it all started to look a bit desperate. The ones in black, by the way, are still ongoing. There are still some studies, so I can't rule those out yet. But it did all start to look a bit desperate. But things have changed recently, as Jay mentioned. So aducanumab, I've put in orange. Aducanumab was a compound developed by Biogen. Now it's interesting because aducanumab, passive immunization approach, predominantly MCI due to AD, but also mild AD. They did 2 very large studies. There were over about 1,300 people in each study. So I think they called them Emerge and Engage. And then in March 2019, they did an interim analysis of their data, and they said the studies have failed, that there is no response. And then a curious thing happened. In October 2019, they turned around and said, we've changed our minds. When we've looked at the data, what we found is the people that we left behind, people in the second study actually did seem to show some improvement in their ADAS-Cog. And when we looked at the original study, which was the Engage study, these people who we thought hadn't done very well actually did do well if they had a high dose of aducanumab. So with that evidence, they then went to the FDA and asked for a license. And as we've heard, FDA looked at it and they've actually
Clive, I think you've been put on mute.
Am I there now?
You're back, yeah, thank you.
Yeah. When did I have to stop? Go back to aducanumab story?
I think it was only about 5 seconds or so.
Okay, so the aducanumab study, when they did the futility analysis, they'd shown that it had failed. But when they looked at the study again in October, they said, no, actually it worked. And so they went to the FDA and asked for a license, and the FDA basically turned them down. They said, you need to come back with another study. Now, they are continuing an open label extension of the original people in this study. And I think they're sort of hoping that the FDA may change their mind on longer term follow-up of these patients, but I think it's highly unlikely. But aducanumab may come up with some goods, who knows. The other interesting one is donanemab. Donanemab is interesting because, again, this is a study by Lilly. Lilly put a lot of money into solanezumab, which was a soluble, which attacked soluble A beta. Donanemab was just focused on aggregated A beta, and originally this study was actually with a BACE inhibitor, so it was a joint 2 drugs together, their BACE inhibitor with donanemab against a placebo. And as we've heard, the BACE inhibitors failed, and theirs also clearly failed, and so they removed that arm. And I suspect, hopefully nobody from Lilly in the audience, but I suspect Lilly were as surprised as anyone really when they actually announced at the beginning of this year that donanemab has shown some signs of improvement on ADAS-Cog and even on some secondary measures. So they are now moving into phase 3 studies. So it's possible that these drugs might come through with something, but I would say there's a health warning. If an interesting paper just published in ACLI in BMJ, some of you may have seen it, has had a look at what the effect on someone's cognition of removing amyloid is. And they've looked at a number of these studies and also some of the beta secretase studies. And their conclusion seems to be that removing amyloid isn't making that much difference to cognition, in fact. Some of the studies, even some of the best studies, seem to be talking about an improvement of 0.1 of a mini mental state score. So I would say unless these studies and lecanemab and donanemab are coming up with bigger effect sizes, one of the problems they'll have, as well as all the hurdles we have around setting up clinics, etc., is convincing NICE that they are a big enough effect size. Finally, I said at the beginning that A-beta was used in that mouse model as a sort of vaccination against the development of Alzheimer's. And these compounds are indeed being used as a potential vaccination. And there's a few of these studies still ongoing. Novartis have injected large numbers, over 1,000 or so, patients who are E4 positive but cognitively normal. Eisai and Lilly, with their compounds solanezumab and lecanemab, are also doing a similar approach in cognitively normal but amyloid positive individuals. But probably the most interesting of all is this idea of immunizing against for these patients who develop amyloid because of mutations. These are the patients, of course, that started off the whole amyloid cascade hypothesis. The cranazepam study, Genentech, is still ongoing, but the DIAN-2 study is now completed. So this is of APP, PS1, PS2 patients, cognitively normal, but amyloid positive. Now, the Lilly study has now pronounced that it was actually negative. So that is a big blow to the amyloid cascade hypothesis. Roche, rather strangely, since it used the same population group, said yes, their studies also failed, but they were suggesting that there were some patients who had symptoms and some who didn't, and those without symptoms may be getting some protection. So they're following them up for longer. But overall, I would say that all of these studies combined do not give the amyloid cascade hypothesis any bonuses, I tell you. So it makes one think that perhaps we should be looking elsewhere for a treatment for Alzheimer's. The jury's not out yet, of course. We've still got some studies coming in, but all the more reason to be looking at other approaches. So if we follow the cascade through, the next obvious approach would be to hit the tangles. So tangles, as I say, are produced from the phosphorylation of microtubule tau, which normally stabilizes microtubules, but with kinases, the phosphorylation occurs and they form these tangles within cells, which ultimately causes cell death. So one of the first ports of call would be to inhibit those kinases. And very early on, there were studies which tried to inhibit GSK3, and all of these studies have failed. So the next port of call really has been around inhibiting aggregation of tau or destabilizing tau. And there's a number of studies in phase 1, but the biggest studies by far are REMBA and tau-rex. Now, REMBA is also known as methylene blue. And this compound actually did make your urine go blue, was one of the problems with the study. The original study was done in Alzheimer patients, and it showed no evidence of any efficacy. The manufacturer said that was probably because of poor bioavailability of REMBA, and so they've tweaked it to now be developed into this compound tau-rex. And because of the problems of potential unblinding, what they did in those studies was they introduced a very small dose of tau-rex as a placebo, just about 4 milligrams, which also made your urine blue. So there was no problem with unblinding. Taurex have now announced that their Alzheimer's studies have failed. They did a behavioural variant as well, and that also failed. I think Taurex are now looking rather like the AD0112 study at the idea that the placebo, the 4 milligram dose of Taurex, might have been have potential treatment properties. But I think as far as I'm concerned, that those studies have really moved into the failed list. So are there any other ways of stopping the accumulation of tau? Well, taking the lead from the amyloid approaches, we can actually immunize against tau. Tau is thought to move from cell to cell through the extracellular environment, and so it is a potential target for immunization. There has actually now been one tau active immunization study which was reported from Axon Neuroscience, a reasonable sized study, 24 months in mild to moderate Alzheimer's. That compound did produce antibodies, and there was some biomarker potential of some slowing of the neurodegeneration as shown by a slower increase in neurofilament light, which is a marker of neurodegeneration, but there was no cognitive benefit. And I'm not sure whether or not they are pursuing that any further. The biggest activity really is in passive immunization, lots of phase 1, phase 2 studies going on there. But again, there has been one phase 2 study which was finished, the Genentech compound, which completed July of last year. This was a large study, over 450 people with early or probable AD, 18-month study, and it completely missed its primary and secondary outcomes. So it didn't show any evidence of any cognitive benefit. And more worrying, there was no evidence of any, as worrying, there was no evidence of any reduced tangle formation. So very early studies, but quite disappointing couple of early results. So that leads us to another target, which is inflammation, shown here by microglial cells. Why would we be interested in inflammation? Well, as I said, the amyloid cascade hypothesis is based on a very, very few people. The genetics of early onset Alzheimer's disease, very rare. But late onset Alzheimer's disease has now been thoroughly explored in very large genome-wide association studies. And what all of these studies seem to be saying is there are lots and lots and lots of genes which have an effect in late onset Alzheimer's disease. But one of the big functions of these genes is inflammation. So inflammation very clearly is important in the development of late onset Alzheimer's. There's absolutely no question of that. One of the elephants in the room, though, is that people have already done studies looking at anti-inflammatory agents in Alzheimer's, and that was based largely on the finding that people who are taking drugs for rheumatoid arthritis, a condition which increases your risk of developing the disease, seem to have a reduced risk. But the early studies, such as the one with indomethacin at the top, which started this whole ball rolling, were soon repeated and shown to be negative. And indeed, all of these studies in various different compounds of anti-inflammatories, and I've included some statins here, have pretty well all been negative. In fact, some of them, so I should say neutral, i.e. showing no effect, but some of them have actually, such as the rofecoxib, have actually showing a worsening of cognition. And so this, in many ways, put people off, and that's probably why people have not focused on inflammation until more recently. The reasons for their failure is probably that these drugs don't actually hit the target we're interested in, which is microglial cells or the production of TNF-alpha. And microglia has now become very much a target of a number of different drug compounds. And the main target is all through a similar sort of pathway, which ends up with a production of TNF-alpha, which is a pro-inflammatory cytokine, or interleukin-1, another pro-inflammatory cytokine, which ultimately leads to neuronal cell death, or alternatively through the role of microglia in its phagocytosis. So you might want to reduce the production of TNF-alpha interleukin-1 by inhibiting those ligands across the top, but you might want to stimulate the ones that increase phagocytosis, the chomping up of amyloid, if you like. And there are various compounds which have been tried. The ones in black are still in very early development. There have been a couple of early phase 2, phase 3 studies which have failed in this area, but there has been now one study which is actually showing some positive effect. Mastanib has shown some effect in cognitive outcomes in Alzheimer's disease. It took 7 years to complete that study, but that study is clearly positive, and now they are underway for larger phase 3 studies. And then there's another couple of approaches which don't directly hit microglial cells, but are clearly anti-inflammatory approaches. The first one is this GRF6019. I just thought this was interesting, really. This study arose from studies of parabiosis. Now, what you can see in the slide, there are 2 mice which have had their bloodstreams connected. And one of these mice is an old mouse, and the other one's a young mouse. And what they found was that the old mice, their cognitive abilities improved when their bloodstreams connected to the younger mouse. These early studies actually led to a flurry of strange things happening in Hollywood, where older people were getting plasma infusions from younger people, and there was actually an FDA warning them against it. But the actual company who were developing this method weren't going to do anything as crude as that. What they actually did was they isolated a plasma fraction of about 400 proteins that they thought might explain this effect, which had anti-inflammatory and anti-aging properties. And they actually did do a phase 2 study in Alzheimer's, and that was announced early on last year as having failed. I've mentioned this before, so I thought I'd just give an update. What really came out of the blue, I think, was this GV971. This was a study done in China. It's a compound derived from a seaweed, sodium oligomannate, and it's thought to prevent astrocyte-mediated inflammatory response and also reduce brain infiltration with immune cells. That's the sort of thing that happens with active immunization with amyloid. They did a phase 3 study. They actually did a phase 2 study before this, which actually failed, interestingly enough. But they did a phase 3 study with a different dose. And that 9-month study did show some evidence of improvement with the ADAS-Cog. A similar sort of effect size to that we might see with donepezil, for instance, but it wasn't significant with their secondary outcomes. Now, interestingly enough, as you can see from the picture at the bottom there on the right, this now has got a conditional license in China, is actually now being manufactured in China, and I think it's had a conditional license for about a year. The FDA have just recently agreed for a phase 2 study of about 2,000 people in the US and Europe to see if that result can be replicated. And if it's replicated, of course, it would lead to a licensed treatment in the US and Europe. Finally, just the last couple of slides, very briefly, just for completeness, really. Neuronal cell loss. The thought of reducing neuronal loss or improving synapses seemed to be a bit of a tall order, really, until a few years ago. There was some very early studies, such as the CER110, which looked at surgical implantation directly into the hippocampus of nerve growth factor. That study actually was shown to be negative. But since then, there's been more sophisticated approaches which basically in infusion form or tablet form appear to improve neuronal survival or promote neuronal growth. A lot of these are still in very early phase, but one of them has actually reported, the one in green here, GV1001, and that appears to improve neuronal survival by protecting neurons from redox reaction, and that has shown some evidence of beneficial effect in mild to moderate Alzheimer's, and so that is progressing to phase 3. And then very finally, the study approaches I've mentioned, of course, have been very much focused on the amyloid cascade hypothesis, but because I think of the the failure of a lot of those treatment approaches, there are more and more other approaches are coming through which aren't so obviously based on that cascade. And so a number of compounds which are anti-diabetic agents are being tried. We, for instance, did a study on liraglutide. The initial outcome for that study was negative. This has been reported in an abstract showing the blood perfusion, which they hoped to improve, didn't improve, but the cognitive outcomes seem to be positive, as described in that abstract. We'll have to wait for the full paper on that. Big studies on antihypertensives, on the idea that hypertension might be a risk factor. Both of these big studies have failed. And then there's a more maverick approach, which is looking at a wide variety of antimicrobial agents, anti-herpes, and also atorvastatin, which is also an anti-ginger pain drug. And we're actually doing that study in MARC. And there's various dietary supplements which I won't go into at this point, but a wide variety of different approaches. So finally, just finished slide, last slide. Overall, I would say that the amyloid therapies have failed to live up to their hype or hope. They haven't really brought us where we thought they might, and I do worry about the effect size. I think there's going to be a lot more anti-tau therapies coming through, very early days, but those couple of early studies are a bit worrying. I think, and I'm probably have to admit to being completely biased here, but I think the big area of development will be anti-inflammatory, anti-infective agents, but we do need to know more about the biological processes. Neuronal support may be coming through, but it's very early days. And I think what will be really interesting is now we've been unleashed from the amyloid chain, that we might actually start seeing some more maverick approaches which might come up with some better treatments. So thank you very much.